Hello, everyone, and welcome. This is Anna Beth Brown with the North Carolina Learning Collective. Your lines will be muted during the webinar, but we welcome your questions. Please type them in the box, and Dr. Mims will take your questions at the end of the webinar. I'd like to take this opportunity to remind you that in this monthly webinar series on May 9th at noon, we'll have another webinar on increasing physical activity, including walking more. And in June, we will have North Carolina's response to the opioid epidemic, data, policy, and practice, and that will be June 13th at noon. In July, we'll have a webinar on motivational interviewing on July 11th, and the time will be different. It will be at 1 instead of at noon. That's at noon on July 11th. So we're looking forward to those webinars. Today, we are just delighted to have Dr. Adrienne Mims, who is the Vice President and Chief Medical Officer for Alliance, the Medicare Quality Improvement Organization for Georgia. Board certified in family medicine and geriatrics, Dr. Mims also worked as a medical administrator for 25 years in the field of quality measurement, healthcare systems design, patient education, preventive health, and population research. In her current role, she works to improve the quality of health for Georgia and North Carolina beneficiaries. Dr. Mims, we're just delighted to have you, and I will turn it over to you.
Thank you very much, and it is a pleasure to be with you today, and all of you who've taken the time to listen to this webinar. Our focus today is going to be looking at using antibiotics wisely for adult patients in primary care. And this is a very important and timely topic because it's time for us to really look at how we have been practicing and how we also as patients have responded to when we thought we needed an antibiotic. There's been some consequences to our approach to using antibiotics, and that's the purpose of us talking about that today. You may have heard the term antibiotic stewardship, and that is why we're going forward with this discussion. Let's see. All right. I wanted to put in a quote here from our recent director of the CDC because they are our national center that looks at infection prevention and control nationally, and they are our major think tank on all things about diseases. And he noted that if we're not careful, we'll soon be in what's called a post-antibiotic era. And some patients and some organisms were already there. That is, we'll be in a situation where antibiotics are no longer working. What we're seeing now is that there is over 2 million illnesses that are currently caused by organisms that we can't treat. And of those, some people are dying. It's costing billions of dollars a year if we look at our healthcare spending on managing and treating these illnesses. They go all the way to the intensive care and then still are not successful. And if we think of the people who are lost or the time that they're lost to these antibiotics that are resistant to everything we have, their loss of productivity to society is quite high. So when we step back as a nation and look at this problem, we have to look at the origins as to where it's coming from. And antibiotic resistance is something that we need to go upstream and do something different about. Now, we liberally use antibiotics, but as a clinician, I have to be aware that anyone that I prescribe may have side effects. And you listening on the phone are aware of these or may have experienced them. You might have been a little nauseous, or you might have been throwing up some, or even having diarrhea. Some women may have noticed a yeast infection after using antibiotics for like a bladder infection. We know of people having allergic reactions and breaking out, or really having anaphylaxis or trouble breathing as an allergic reaction to an antibiotic. And there are some that are very potent that we reserve, but sometimes we have to use them and they can cause kidney damage. But I want to focus on the last one on here, this diarrhea, because it has significantly increased in proportion over time. Now, there was a little bit of irritation to the stomach that caused the diarrhea, but now what we're noticing is that when we're using strong antibiotics, they kill off the bacteria that normally protects us in our bowels. And there becomes this overgrowth of this germ called C. diff that causes a very severe diarrhea. And in people who are more frail, it can cause them to be hospitalized and even die from it. And this has really caught our attention that we have to look at what we're doing, because C. diff is not new. It's an organism that's been around a long time. But for now to have rising rates of people with C. diff diarrhea being hospitalized and dying, we need to look at what we're doing upstream. So on this graphic, we're looking at the United States, and specifically North Carolina. We look at the rate of all antibiotics that are prescribed in the population. And we're looking at 2014, but that's recent enough. And unfortunately, there's some variation. Why would there be variation? We might say maybe there's variation in the outpatient setting due to influenza or colds, but it really shouldn't be this wide a variation. I'm just glad I'm not in those dark blue states where we really have to put some concentrated effort. But there is much to be done here in both Georgia and North Carolina. There should be some similarities in these states. I want to focus a little on this slide here. And it's important because it tells us more information that's been published that documents our overuse of antibiotics. Now, on this slide, there are bar graphs, one for sinusitis or sinus infection, and one for pharyngitis or sore throats. And in each one of these, which we'll look at the one on the left first, we're looking at sinusitis for both the pediatric population and the adult population. And each one of those have two bars. Well, the bar called first line, that is saying how often a person was treated with an antibiotic with the preferred first line antibiotic. Whereas the non-first line is how often they were given an antibiotic that probably was overkill, probably cost a lot more too, but has the potential of killing all the bacteria in their body that we're not really trying to target for that sinus infection. And when we focus specifically on the two bars of adults for sinusitis, the first line looks like it's less than about 30%, whereas the non-first line is approaching more than 60%. So we have created a pattern that we're doing for a simple sinus infection. We're giving out big gun, very costly antibiotics, which are not the ones that we really need to be focusing in on for this condition. More specifically, the guidelines have changed in that most sinusitis are viruses, so need no antibiotic at all. But when we give an antibiotic, it should be something like amoxicillin or augmentin. But yet we're doing a lot more other broader spectrum antibiotics. Then likewise, when we look to the right at the pharyngitis, we see the same thing. The only pharyngitis that should be treated with an antibiotic is strep throat, and it should be treated with penicillin class medication. So we see the dark blue with the legend penicillin or amoxicillin. But yet we see for even pharyngitis in adults, far more treated with non-first line antibiotics. And this is a habit that we've developed over time. It may have come from marketing or easy to dispense, but we're giving broader spectrum antibiotics for simple conditions very commonly in outpatient. And this is published in the literature, and this is national. Now let's look at North Carolina data. This is looking at a group of Medicare patients in North Carolina, looking at all of them and their data from 2015. We chose the time period of January to end of September, and all of them who were seen with a diagnosis of an infection and whether or not they were given an antibiotic that we considered a first-line antibiotic based on evidence-based guidelines. Well, the good news is that for pneumonia, more than 80% of the time, that is what people will use. But as you see on these other common infections that occur in the outpatient setting, and all of these were outpatient setting, we see lower rates of people using antibiotics that were considered first line, and more specifically, home in on the urinary tract infection or UTI, less than half of the time were we focusing and using the first line antibiotics. That gives the potential for overgrowth and people having diarrhea, having C. diff, getting hospitalized, having resistance to medication, and potentially dying. So as I go to my next slide here, these are the commonly prescribed antibiotics that we have been seeing on that graph that are not considered the first line. And I'll focus in directly on urinary tract infection. We see in here that multiple antibiotics are being used, but yet the preferred one are sulfur, the sulfamethoxazole trimethoprim. So these are the ones that are being used. For pharyngitis or strep throat, we're using azithromycin or Z-Pak. No. For sinusitis, likewise, a Z-Pak, doxycycline, those are not the preferred ones. Augmentin is number one for sinusitis. So let's look at more of this database that we got. And we say, well, maybe it depends on where they went to get care. And the legend looks at emergency departments for blue, outpatient provider offices for red, and federally qualified health centers for green. And this is looking at the people who were seen for those diagnoses in those settings and whether or not they were treated with the appropriately prescribed preferred antibiotic. And as we see, there's some similarities across all groups in terms of their prescribing habits. And it's very good to see that the federally qualified health centers lead in every setting and every diagnosis. In every diagnosis, they're more likely to use the preferred antibiotic. And is that because they don't get as much detailing from different drug companies? I don't know. But it's good to see that they are higher, but still they're having challenges in urinary tract infection. Sometimes you can improve your choice of antibiotics in an area just by having a protocol. So all that I have shown you has led up to the need for antibiotic stewardship. And it is prescribing antibiotics only when they should be done. It is getting antibiotics appropriately on time and ensuring that we have the right drug at the right dose for the right length of time when we select an antibiotic. And if we do this, we can decrease that curve that we're going toward this post-antibiotic era. We could have less adverse events. We can have less C. diff and deaths. So how do we do that? What I'm looking here is some data on avoidance of antibiotic use in adults with bronchitis. And if we look at this for the 18 to 64-year-old, we can see that we're overusing and overtreating with essentially a chest cold. So we need to kind of look at acute bronchitis and call that a chest cold And I just wanted to show you the data I showed you before was on over 65, but this is on data that's lower than 65, 18 to 64. And this information, I think, is important to note that our challenge with this is far more than just in the adult range. This data is looking at information specifically for North Carolina HEDIS data, and whether you're talking about HMO, PPO, or the like, all of the years show that we're still consistently treating a chest cold or acute bronchitis with antibiotics. When we think of trying to decrease the rate of treating antibiotics with the common cold, there is a national measure called Healthy People 2020. Stop using antibiotics for the common cold. And that's where this red line is across the graph. And at these 3 different time points, they all look identical in that we are not decreasing in using antibiotics for the common cold. So the Centers for Disease Control, as I mentioned before, they are our national leader in guiding us on infection prevention and control. So they recently released in 2016, I think it was about November or December, this core elements for outpatient antibiotic stewardship. It's a wonderful guidebook to help us do better in this area. They are focusing on these particular groups here. Primary care, because that's where most antibiotics are written. Primary care, emergency, dental clinics too. They write a lot of antibiotics. And then the other areas that are listed here, including those retail clinics like Minute Clinics or those ones that are in the pharmacy or Walmart, and then in some healthcare systems. But they wrote this to specifically target the groups of people who are doing a lot of the antibiotic prescribing appropriately and treating people, but then also prescribing antibiotics where we need to modify our behavior. So for this, we need to demonstrate commitment. They give us tools on developing actions, tracking and reporting, and finally having the education that we need to move forward. So the toolkit says that in order to have an improvement in one system, it's helpful to work on these core elements. And they have used this model in both hospitals for many years and in long-term care. But they have modified these core elements specifically to the outpatient setting. And a focus on these in those settings could make a vast difference in our antibiotic use. So let's say, for instance, you say, well, gosh, Dr. Mims, this is great. Let me get started. This is some areas to think about in your facility, whether you're overprescribing for acute bronchitis or otherwise a chest cold. If you're overdiagnosing like strep throats and treating them as though they're much broader than just the penicillin, which is sufficient. Or if we're using the wrong agent, a lot of use of azithromycin, especially for sinuses and urinary tract infections, or some places where it's underused. Well, as we begin to look at trying to improve, it's important to pick one area to focus on. And let's say the overdiagnosis of urinary tract infections in older women is one particular area. And if you're familiar with the Choosing Wisely campaign, it is a national effort to make sure that we're having a dialogue with our patients and deciding when it's appropriate to do a test or treatment or procedure. And in this case, we are over-treating what we think is a urinary tract infection in older women when many of them will always have bacteria in their urine, but not an infection. So there's some information for both the clinicians on this web link, but also the Consumer Reports has joined with the Choosing Wisely campaign to create patient-friendly materials that support this effort. I mentioned that there are guidelines, and there are the 3 sources listed at the bottom there that are related to all of the common diagnoses in an outpatient setting. And this is a table I took directly from those guidelines. So acute sinusitis, I know that's bread and butter. We see so much of it. But 90% of those cases are viral and do not need an antibiotic. 90%. So what we do is we want to wait and see if it's very severe, such as high fevers and pus with facial pain, or after 10 days, they're still having symptoms, or they were moving along and then suddenly got worse. X-rays are not indicated. So the layout of this table is what you find on these reference tables for each one of the infections and can more appropriately guide us in how to diagnose and when to treat. Now, another part of this table, which I'm not showing you, is the column that has the appropriate antibiotic. Those references are all available to use. So if you decide to begin on an outpatient antibiotic stewardship program, identify one, just one high priority condition. You can choose pharyngitis or UTI or sinusitis. Just pick one. Then identify the barriers that are causing us to start using Z-Paks or overprescribing. And then develop a standard of how that should be treated and ensure that everyone in the facility is on board with the new approach. The CDC in that core elements guidebook has in the back a wonderful checklist that one can use for quality improvement. You can do this at your baseline before you start an antibiotic stewardship program, and then track your progress over time, like quarterly. Just look at the 4 questions and say yes or no if you have something that you're doing in those areas. And if you are, you put a checkbox on the ones that you are doing. Recently, we have embarked in a new quality payment program under Medicare. And this quality payment program changes the way people who see Medicare patients are reimbursed. Now, I won't go into much detail on that. Suffice it to say that most people will be in one of those forms of payment called the Merit-Based Incentive Payment Program, or MIPS. And in that MIPS program, it divides up 4 different categories of how people can be incentivized or get a penalty from their Medicare billing. One of those being an improvement activity. Well, it just so happens that what I've described thus far as an antibiotic stewardship program serves as one of those improvement activities. There are many improvement activities, and as you see here, I have a star. Implementation of an antibiotic stewardship program counts as one of the ones that Medicare realizes is important and will reward for the participation in such a program. If you're going to do this type of program, have a model. We recommend the model for improvement. It's a good model for quality improvement that your whole team can focus on. What are we trying to accomplish? How will we measure if there's a change that's improved? And what are our ideas that we can test one at a time through a plan, do, study, act cycle to ensure that we made some improvement? And so when we begin to embark upon this, we'll start first and say which population. We may say our Medicare patients, our women, and we specifically look at urinary tract infections. And what are the guidelines? What do they tell us? Well, they tell us that maybe we should not be using as many antibiotics. And we can look back at our charts and see what our baseline measure is. And then develop a SMART goal as to where we want to go for an improvement measure. Together as a group, as your team, you can conduct a RCA or root cause analysis to figure out, well, why is it we keep giving these antibiotics in this situation? What is the trigger? Is somebody inadvertently ordering this urinalysis? Are we checking for the wrong symptoms? Is it just because they said they had a foul odor? And we check and pick one of those and do a plan, do, study, act cycle around improving those, and we measure our performance. And as I mentioned before, the model of improvement has plan, do, study, act, and spend most of the time on plan. Plan before you start to implement. But within the plan, decide how you're going to measure what the change is. So I'm going to begin to close now with inviting you to consider joining an antibiotic stewardship program. We have been funded by Medicare to provide support to any practice that would like to do this. Our support is free. We will help coach you to help ensure that you minimize the development of resistance and ensure that each patient receives the right antibiotic at the right time for the right dose and the correct duration. When I initially trained, almost every infection was 7 to 10 days, and many are only 1 dose or 3 to 5 days of medicine. And if you choose to sign up with this collaborative, you will be provided access to patient education materials so that patients will know in the conversation with you why it's not best in their best interest to use antibiotics. You will then have a lower cost to your practice compared to your peers who are still using Z-Paks for sinusitis, and that will be viewed favorably by insurers. This will be used to improve some of your quality measures for infection and antibiotic use, and as I said before, can be used as a improvement activity for MIPS. So at this point, I will stop and I will leave the slide up with my contact information, and we can open to see if there's any questions. Thank you.
Thank you, Dr. Mims. That was really interesting, and I know those of us in North Carolina are really interested to see that North Carolina data. Thank you. We do have one question. Can one develop resistance if given too much of an antibiotic?
One can, and resistance is not really the person developing resistance, it's the bacteria that you're trying to treat. So if you're given a large dose of an antibiotic at one time, that will not cause resistance. If you're given the same antibiotic for ear infection multiple times, later on, by third or fourth course, that may cause resistance. Our real problem with resistance is using antibiotics that are broader and kill more bacteria than what we need to for the one organism that's causing the disease. So with a sore throat or a strep throat, we should use the antibiotic directly killing the strep throat. The problem is that we're using antibiotics that's killing 20 different things, and those 20 different things, the bacteria keep seeing these antibiotics and they're developing resistance to those. Thank you for the question.
Thank you. That's very interesting, and that explains why you were talking about how important it is to treat with the proper kind of antibiotic, or it can develop all kinds of problems. Another question is, could you please comment on the long-term use of antibiotics? Some people are on a low dose for acne or something like that. Can you comment on that, please?
Sure can. And so acne antibiotics, we already know that the germ that causes acne is very specific and very maybe 1 or 2, and they are well treated with a specific antibiotic. And that one used in low dose over a long period of time, even years, is still effective because it's not developing resistance to that particular antibiotic. So it's very safe to use. And that may happen also when we're trying to do long-term prevention of certain other types of infections. if we use the specific antibiotic rather than a broad one, it's very safe to do that. Thank you.
Great, thank you. That's very interesting. Are there any other questions? If you have questions, please type them in the questions box. This webinar was recorded, and we're going to post it on Start With Your Heart. So if you want to recommend this webinar to your colleagues, or you want to look back at some of the information and resources that Dr. Mims described and her contact information, it will be posted on our website in a few days. I want to thank you so much, Dr. Mims. This was really interesting and really helpful and exciting to think about being able to use this as an improvement project in practices. Just want to take a moment to remind folks we have our next webinar on May 9th at noon, Increasing Physical Activity, including walking more. And then on June 13th at noon, North Carolina's response to the opioid epidemic, data, policy, and practice. And then in July, our time will be at 1 o'clock instead of at noon. July 11th, we'll have a webinar on motivational interviewing. So we're looking forward to those. Thank you all very much for joining us. And thank you so much, Dr. Mims, for a really great presentation. Thank you.
Thank you. Goodbye.